Moving on to the next presentation, may I now invite Dr. B. Senthilkumar to the stage. Sir has done his MD and DM in pediatric neurology. He is a consultant in child neuro clinic in Salem. Sir's area of expertise includes in epilepsy and developmental pediatrics, and he has 15 years of teaching experience and has publications to his credit. Over to you, sir. Dr. B. Senthilkumar.
Good evening, everybody. At the outset, I thank the organizer and my dear friend Dr. Anbu for inviting me here. I think this is not moving, huh? So before I start, I request the chairperson to give me 5 more minutes because I have a lot of videos to play and I assure you that it won't be boring. So today's topic I am going to discuss is about approach to a seizure in a child. So what I won't be discussing is, I won't be discussing about any definitions, classification, or the statistics. So instead I will be showing some interesting practical videos, and for practical purpose I have classified into 3 levels. The level 1 will be treated by a general practitioner or pediatrician with history, examination and an appropriate imaging, and of course supplemented in level 2 by an EEG by a neurologist. So the need of epileptologist is less than 10%. For example, in refractory seizures, immune epilepsy, genetic epilepsies, and that thing we won't be discussing today. So this is the overview. If you are seeing a child with the first seizure, either in the active convulsing phase or with the recent history of seizures. Of course, when you see a child with seizure, the priority takes for ABC. So after maintaining the airway, breathing and circulation, the drugs stop out the seizures, which we'll be discussing in the later slides. Once the child is stable, so the next initial step will be to assess the history, whether it's a true seizure or a pseudo seizure. If it is a pseudo seizure, give reassurance. If it is a true seizure, if fever is present and it's a sick child, you have to rule out meningoencephalitis or a normal sensorium, febrile seizures. Other etiological history you have to go about. And in case of unprovoked seizure, you try to find etiology by imaging and specific management. So each and every aspect we'll be discussing in detail. So if you are the first person to see a child with seizure and if you want to start treatment, I think you should spend some time in deciding whether it's a true seizure or not. Because once you start an anticonvulsant, then that child will be branded as a known case of seizure disorder and a second doctor will hardly think about it. They will keep on adding the anticonvulsant. Unlike adults, children, there are a lot of conditions which mimics a seizure. So some of the common one. So though in a textbook you can see a lot of difference between a true and pseudo seizure. For example, occurring in the night, associated tongue bite, whether in the tip of the tongue and the lateral tongue bite, urinary incontinence, frothing, all even serum prolactin levels, everything, nothing helps you in practice. But the only thing which helps you is just see the eyes. If you closely see the eyes, see the child is holding the cord to prevent the fall. And if you see the eyes will be invariably closed in all the pseudo seizures. And there are hardly any true seizures with closed eyes. Even in a newborn or whatever be the seizure, the eyes will be either open, stare, gaze to one side or up gaze, or eye blinking will be there. So the DSM has classified this as a case of functional neurological symptom disorder. Of course, you need a psychiatrist help for psychotherapy and behavior modification. Oh, sorry. So this is another common thing. Because of the home videos, we can easily identify this. You have a symmetric twitching, clonic jerks of both the lower limbs. So this is a benign neonatal sleep myoclonus. See, again, the child is comfortably sleeping. If you see the child is comfortably sleeping. If it is a true seizure, definitely the child will be disturbed, sleep will be disturbed, some amount of staring will be there. So it's all a self-limiting condition. But this is a very unfortunate child. Actually, this child was admitted in another hospital. The child used to get, sorry. Oh my God. Previous one, this is not working. You have to click the video there. Yeah. So actually, child used to get these kind of episodes. Actually, the pediatrician there suspected, audio is not coming, audio. Uh, so the pediatrician suspected it as a repeated kind of seizures. He loaded with anticonvulsant. In spite of 3 or 4 anticonvulsants, the child didn't have stoppage of these episodes. So the pediatrician has explained to the parents that this is a severe thing and the child may go in for sequelae. And in a bit of emotion, actually, the mother jumped from the 3rd floor and committed suicide. This case has been referred to our hospital, and when I saw this is a typical hereditary hyperexia. When I asked the history, the mother had a similar episode, and she used to get frequent falls whenever she becomes emotional. So this usually responds to clonazepam. This now the child is 5 to 6 years old on minimal dose of clonazepam and doing well. But of course, if there is developmental delay, you have to rule out other startle syndromes and inborn error of metabolism. So this is another common entity. So after a severe cry, the child becomes see the mouth and tongue. You can note the cyanosis. The child becomes breathless and goes in for limp and passes off. Sometimes you can even see some tonic posturing, but usually clonic jerks are rare. So this is a common breath holding spell, cyanotic breath holding spell. So the association between anemia and breath holding spells have been clearly documented, and supplementation with iron and pyracetam for 3 to 6 months clearly reduces the frequency. So the related event is RAS, that is a reflex anoxic seizures or a reflex anoxic syncope. The history will be like this. When a child was playing, bumps against an object or falls, becomes pale, have a tonic posturing. This is also a non-epileptic event. And the next group of events are paroxysmal dyskinesias. Paroxysmal dyskinesias usually can take the form of either dystonia or choreoathetosis. We classify into 3 types: paroxysmal kinesogenic dyskinesia, non-kinesogenic, and exercise-induced dyskinesia. Once the child have a particular act, the left hand goes in for dystonia. This is a case of PKD, idiopathic type. They also respond to your phenytoin and carbamazepine. This child, again, there are 2, they are siblings. The elder child, after he plays for 5 or 10 minutes, he can play normally for 5 to 10 minutes. Once after 5 minutes, see the video on that side, the lower limb goes in for dystonia. He won't be able to walk further. Again, you have to take rest to recover. Usually when you see these kind of lower limb dystonia, you have to rule out dopa-responsive dystonia and glutamate deficiency. But both the children had a pallidal hyperintensity in MRI, so that indicates probably mitochondrial disorder of pyruvate dehydrogenase deficiency. We sent for genetic testing, but interestingly, it came out as a ECHS1 gene mutation. Actually, worldwide, only 3 cases has been reported. This has been the first case from India, and they responded beautifully to thiamine. Now they are absolutely symptom-free, both the children, with thiamine supplementation alone. This is another common thing after domperidone or an antipsychotic. See, the eyes are upwards, neck in the dystonic posturing. So this is a case of oculogyric crisis, dystonia secondary extrapyramidal reaction. They respond to your tetrabenazine, diphenhydramine or lorazepam. And of course, you should not use the drug in future. So this boy has a rapid repetitive movements. Either it can be simple motor movements, or in this case, if it is associated with vocalization. So these are called tics, and when it is associated with other behavioral abnormality, vocalization, less than 18 years of age, we call it as Tourette syndrome. They respond to clonazepam or dopamine depleters like tetrabenazine, haloperidol, and even clonidine can be used. So another common entity is an young child, a toddler, who crosses her limbs. It can be as mild as this, or the child can become very hair perspiring, even grunts, sometimes child grunts on this age, or this is what we call as self-gratification behavior, previously called as infantile masturbation. and only reassurance and distraction techniques are useful. See this child? What you notice is nodding of head, some amount of torticollis is there. And if you closely see the eyes, the left eye has a nystagmus. Actually, it's a unilateral nystagmus, though they can have bilateral also in this condition. So this combination is called a spasmus nutans. This is actually a benign condition, but once you see a child like this, you have to do an MRI to rule out an optic nerve glioma, or if the eye movements are quite bizarre, you have to rule out OMS syndrome, obsoclonus, myoclonus, ataxia syndrome. This child again presented with torticollis, a lot of autonomic features, sweating, vomiting, irritable child. Of course, you need an imaging to rule out a posterior fossa lesion. Everything was normal. So this is a benign paroxysmal torticollis. It's equated to the migraine variant in children. Fine. Once you have reasonably ruled out all those pseudo seizures or seizure mimics, then history is important. Though there are a lot of provoking factors, I would like to concentrate on two things. One is the toxic and drugs, especially an exposure to camphor. You have to ask the children, because most of the children, even at the smell of camphor, can present with a refractory status. And in the recent COVID pandemic, we have seen after that steam inhalation, especially with eucalyptus oil, we have seen even adults with recurrent seizures. We have to ask that history. And in the drugs, bronchodilators and antihistamines, especially they can present with long QT syndromes and syncope. So regarding seizure semiology, how it occurs, though there are a lot of things by which we can localize the origin of the seizures, they are useful only, especially for surgical purpose. But in a clinical practice, the first thing you have to ask is whether it's a focal onset seizures with secondary generalization or a primary generalized seizures, because the treatment management differs. For focal onset, we usually start with carbamazepine or oxcarbazepine, whereas for a generalized onset seizures, we start with either valproate or levetiracetam. But certain history, for example, a nocturnal seizure, typical history will be the child gets up from sleep, drools, stares, vomits, few clonic jerks, and then lies down. So this kind of picture clinically suggests that it should be a benign childhood epilepsy with centrotemporal spikes or occipital paroxysm. The EEG will help you to differentiate these two. But if the child gets up at sleep, behaves very bizarre bipedal automatism, and then goes in for sleep, you have to rule out nocturnal frontal lobe epilepsy. On the other hand, if the seizures routinely occur in the early morning, for example, before awakening at 5 to 6 o'clock, or once the child gets awake, bit of myoclonic jerks, dropping things from the hands, this is the classical of JME. So, few videos about the semiology. Just observe the child. There is twitching on the right corner of the mouth, is the focal motor seizures, simple partial. So, the commonest case is a neurocysticercosis involving the left motor area. But the focal seizures may not be as simple as this. This boy has been having these kind of seizures for months together, and it was not responding to any of the anticonvulsant. So, with MRI, you can see there is atrophy of the left hemisphere with signal changes. So, this is a case of Rasmussen. The child was started on immunosuppression. The child responded well to immunosuppressives, but usually these kind of patients relapse after a period and hemispherectomy is needed. And another common type, almost 15 to 20% of childhood seizures are made by this variety, that is an absent seizures. When it is very classical, observe the child, now he becomes unresponsive without any movement, hardly lasts for a few seconds. Volume please. Now he responds. So this is a classical absence. When it is very subtle like this, there is high chance that it can be missed even by an educated parents. But usually absence, you can see some of the associated movements, especially you note the eyes, there will be blinking of eyelids. So when the child hyperventilates, there is blinking of eyelids, some postural imbalance. And if you closely observe, you can see the automatisms as well. Just see the hands. With the left hand, she is picking her cloths. With both hands, she is flicking the cloths. Now she is rubbing the mouth. All these are subtle automatism. Usually we say automatism occur in complex partial seizures, but subtle automatism occur in about 40 to 50% of absent seizures as well. But whenever you see an older child with absence, And you just observe the child. There is proximal jerking of the shoulders. See this child also. This quite prolonged with jerking. A myoclonic absence is a severe form. They don't usually respond to simple drugs like ethosuximide, valproate, or lamotrigine. They need multiple drugs. You have to add second-line drugs, and both the children needed an amantadine, an antiviral agent used in Parkinsonism, can be used in refractory absence. And when you see a child with myoclonic jerks, this is a classical plexospasm. And so another thing is the extensor spasm in the child below. So it may seem as a mild subtle when the child is lying in the supine posture, but once you lift the child, it will be very violent to see. And when it is associated with other triads like developmental delay or hips arrhythmia, we call it as a West syndrome. Now there are a lot of options available, either injection ACTH, oral prednisolone, or vigabatrin, or you can have a combination. But I generally used ACTH. What is this child? This child, a 2.5-year-old child, came with recurrent generalized jerking of the body. So the child used to get these kind of attacks. So this is a case of SSP, the youngest case I have ever seen, 2.5-year-old. The child contracted measles at 6 months of age and succumbed to the illness. And special types, volume bit please. So this child actually has recurrent laughing and staring spells. He also had a history of seizures. But these are gelastic seizures. This girl has isolated these episodes. There was no other history of seizures. She was fully conscious during the episode. Initially thought to be a psychiatric illness or part of the normal play. Just see at the end of the video, she is saying, Vardhika, I'm not able to control it. Her initial MRI was normal. The follow-up MRI after 1 to 2 years showed a hypothalamic hamartoma, and she has been recently operated. Both the children have been operated for hypothalamic hamartoma. This is another special type. Any minimal noise will precipitate a seizures in these children. So this is called a startle epilepsy, occurs only in severely brain damaged children following HIE, very notorious and resistant to your anticonvulsants. So now coming to the general examination findings, what to see, either adenoma sebaceum, shagreen patches, ashy leaf macule. And when you see a child with myoclonic seizures, see the subtle ashy leaf macule over there. And of course, you can diagnose from seeing the mother. She was absolutely asymptomatic, having adenoma sebaceum. So all these are features of tuberous sclerosis complex. And other neurocutaneous markers like Sturge-Weber syndrome. This is hypomelanosis of Ito. And you can see the shortening between the limbs, explaining the cerebral lesion. This child is quite unfortunate. Anyone can appreciate this one in the right upper eyelid. This is a cutaneous cysticerca. She had an extensive cysticerca involving the entire brain, body, everything. She was tried with steroids, anti-edema measures, everything, but the child developed severe edema, ICP features, had bilateral optic atrophy, and child actually succumbed to neurocysticerca, which is not as benign as we think always. And this child with seizures, recurrent infection, increased IgE, part of Job syndrome. Again, I was telling about the evaluation of sugar and calcium at the initial illness. This child has been treated with multiple anticonvulsants up to 6 years of age. She didn't have any control of seizures. She had mild dysmorphism, had a polydactyly operated. Her CT showed bilateral basal ganglia calcification. She turned out to be a hypoparathyroidism, retarded growth dysmorphic syndrome, HRD syndrome, or the partial Dijorge syndrome. So what are the investigation you need? Basic sugar electrolytes, calcium. If you miss in the first instance, you may not do it later. In a febrile child, CBC, CRP, and lumbar puncture according to your clinician discretion. Lab test should be based on clinical circumstances and toxicology and LP. based on the clinical circumstances. So what imaging is ideal? When to do imaging? If it is a focal seizure, clusters, status, or a focal deficit with a history of trauma or increased ICP, and there is associated developmental delay or dysmorphic features. Only in emergent situations, CT is needed. For example, you suspect head injury or a bleed because the yield is very low, only 7 to 8%. In a non-urgent imaging, MRI is the modality of choice. You can pick up the abnormality in 33%. Few CTs, this is calcification of the torch. This is that basal ganglia calcification of that child having hypoparathyroidism. A subdural vasculitis producing infarcts. This is a chronic infarct with gliosis, an acute infarct, and common thing is cysticercus. This is that girl's CT imaging, the entire brain is studded with cysticercus. Whereas MRI, for all migration anomalies, if you suspect MRI is a modality of choice, this could be a corpus callosal agenesis, agaria pachygyria complex, lissencephaly. This is a focal cortical dysplasia here. There is a subcortical band heterotopia and hemimegalencephaly. All these migration anomalies will be definitely missed by a CT, so you need an MRI brain. And this is connector sequelae involving the bilateral basal ganglia. This is a typical hypoglycemic injury in a newborn, predominantly affecting the parieto-occipital region. And of course, multiple hyperintense lesion in the brain and spinal cord, part of ADEM. This is a case of Rasmussen involving the left hemiatrophy. And this is another interesting case, a child presenting with febrile status. You can see the edema in the hippocampus. These kind of children are very prone to develop a mesial temporal sclerosis and getting a refractory complex partial seizures. This is subependymal nodule and a subependymal giant cell astrocytoma of tuberous sclerosis. So role of EEG in any acute setting, if the child is in persistent altered sensorium, to rule out a non-convulsive status, a EEG is needed. But in a stable child, the highest yield you can get within the first 3 days or the maximum the first 7 days of ictus. You can increase the yield by sleep deprivation, prolonged EEG or repeat EEG. So it is the only investigation recommended for all children with first non-febrile seizures. If it is abnormal, the risk of recurrence is around 54%. So some of the EEGs, the classical absence, 3 Hz spike and wave, it is a slow spike and wave pattern. It predicts a Lennox-Gastaut syndrome. As I said, the previous clinical scenario with centrotemporal spikes, this is the classical of BCECT, benign childhood epilepsy with centrotemporal spikes. But if you see an occipital spikes, it is benign childhood epilepsy with occipital paroxysm. And hips arrhythmia, a bizarre pattern associated with the flexospasm and developmental delay, part of West syndrome complex. Even you can pick up a focal slowing due to cysticercus with edema or any other space-occupying lesion with the help of EEG. And burst suppression pattern indicates epileptic encephalopathy. And this is the classical periodic complex of SSP. Once you see this EEG, no more investigation is needed. This is a classical SSP. So management, so you have to treat if you see any hypoglycemia, calcemia, electrolyte imbalance. In hospital setting, either you can use midazolam or lorazepam. I generally use lorazepam because of its longer duration of action. It gives time for us to decide about the loading of drugs. And for home management, midazolam spray is really helpful, 0.2 milligram per kg. It comes in 2 strengths, one puff is 0.5, another thing is 1.25. You have to be very careful when prescribing the dosage. So few words about febrile seizures. There are 3 types, simple, complex, and febrile status. If it is a true simple febrile seizures, there is no need for any imaging. EEG has no role. But less than 12 years, if you think the child is sick, better to go for LP and CSF analysis. For a complex febrile or febrile status, definitely you need an imaging and EEG and CSF according to the clinician discretion. So what AED prophylaxis, though the recommendation is only an intermittent prophylaxis for both simple and complex, but the AIMS recommendation or what we generally follow is, if it is a febrile status or a complex febrile seizures or recurrent simple febrile seizures, that is if it is more than 4 per year, and I will add one more thing, if the parental anxiety or a fussy parents, better to start them on regular anticonvulsants. So AED prophylaxis is intermittent, either with clobazam or daily prophylaxis. If it is less than 2 years, you can use either phenobarbital or levetiracetam, or if it is more than 2 years, sodium valproate. So anti-epileptic loading is not needed when you suspect a simple febrile or electrolyte disturbance, and there is associated global delay, brain insult, trauma, focal seizures, or family history. Can load with anticonvulsants. You have a lot of choices now: phenobarbital, phenytoin, valproate, levetiracetam, lacosamide, or even brivaracetam IV is available now. So regarding the duration of AED, long-term AED is needed if you suspect if there is a structural lesion, developmental delay, family history, neurocutaneous markers, or brain malformation. So what is the risk of recurrence after a seizure? First, unprovoked seizures with a normal EEG, it's only 15 to 20%. With the abnormal EEG, it is 40 to 50%. So whatever you say, whether to start them on anticonvulsant or not, is always a debate, but generally I do start even if everything is normal. Second, unprovoked seizure, recurrence is more than 50%, and JME there is lifelong risk. That's also. So this is the final slide. BENIGN encephalitis is no other treatment. Febrile seizures I have already told. And few words about neurocysticercosis. The treatment is usually albendazole with steroids for 10 to 14 days. And you have, along with anticonvulsants, you have to repeat the scan at 6 months. If the lesion has disappeared, you can taper and stop. If the lesion is persisting or is gone in for calcification, you have to continue the AED for minimum of 1 to 2 years. So, of course, you need counseling. Parental fears should be allayed. Apprehension, stigma, home management of seizures should be taught. AED duration, complaints, and adverse effects has to be educated. So, to conclude, every seizure is an emergency. You should try to stop each and every seizure because the risk of SUDEP is the sudden death in epilepsy. Though it's rare, incidence is around 1 in 1,000, but not only death, seizure is really a frightening event, not only to the child, to the entire family. So our aim is to stop any further seizures. But statistic doesn't come into play. You can't say there is only 15% chance or 20% chance for a child to get a seizure. The child again gets a seizure, definitely you may not get a second chance to treat the child. Definitely they will change the doctor. So statistics won't play when you treat the patient in practice. Of course, you should know the legal implications of starting or not starting a drug. Thank you, Anandal.
Thank you, Dr. Senthilkumar, neurologist. You have given very elaborative and exhaustive details about the first episode of seizure in children with appropriate video clippings on various seizure and seizure mimics. Thank you very much. Any questions? Any clarifications? If the